Hi, I'm Rich Willy. I'm an assistant professor of physical therapy, and you are listening to the Physical Performance Show.
And the winner is...
Failure is not an option.
I've had my ups and my downs.
Phelps with 10 meters left. 3 minutes too good. The crowd roaring. Freeman gets down.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Listeners, welcome to another episode of the Physical Performance Show. I trust you've been having a great week and you've been out there pursuing your best physical performance also. I hope you enjoyed last week's episode 73 of the Physical Performance Show, featuring up-and-coming rising triathlon star Jake Birtwistle. He's hardly up-and-coming though, as I say that, but he's already a World Series medalist in the ITU Triathlon Series and Commonwealth Games bound in 2018 here on the Gold Coast, representing Australia in triathlon. So if you missed episode 73, jump back over. Jake takes us through his genesis story, going from an okay junior runner on the track through to 11 times track junior champion running, through to his transition into triathlon and beyond. So that was episode 73, Jake Birtwistle. Today's show, as always, is lovingly brought to you by POGO Physio. We exist to help you perform at your physical best, and we do this through our industry-first, fixed-fee, unlimited access, 2, 6 and 12-week finish line programs. What's the finish line? Well, it's real simple. We want everyone who walks through our doors to get a high-five moment where we tell you that we love you, but you've finished rehabilitation. And unless it's for another injury or for maintenance, you don't need to come back. We believe everyone deserves a physio finish line for their rehabilitation. Our finish line programs include active rehabilitation, clinical Pilates, Galileo whole body vibration therapy, Alter-G anti-gravity treadmill running, and of course, hands-on therapy, physiotherapy, remedial massage, and also podiatry. If you're interested in finding out more about POGO Physio's finish line programs, jump over to the website, pogophysio.com.au, and stay tuned for finish line programs coming to a practice near you as the POGO Partners program runs interstate into physio practices in 2018 and beyond. Massive thank you to you, the listener, for tuning in. If it's your first time today, a big welcome. If it's your 74th time, then welcome back. And a massive thanks to the faithful listeners who have left reviews over on iTunes. It really helps get this program in the ears of more people who, just like you, are looking to pursue their physical best performance. And I just want to acknowledge this week Dylan Trineri, who left a review recently on iTunes. And Dylan writes, "I love the way that Brad can interview world-class professionals and the best of the best, but still finds a way to relate it back to everyday runners and triathletes. He asks questions that provoke meaningful and well-thought-out answers. I particularly enjoyed Sam Appleton and Tim Burkle's episodes. He does a very good job highlighting that although they do this professionally, they are still doing it because they enjoy it and love the sport and never have to lose sight of that." So Dylan, thanks very much for the 5-star love of the podcast, and hope you're well. Thanks for taking time to leave a review, and I hope you kick in some racing goals with your triathlon. Listeners, this week for episode 74, we're returning to an expert. The last expert we had here on the program was Peter Maliaris, who took us through the world of tendons for anyone suffering lower limb tendon problems, how to navigate that frustrating maze. And Peter, his episode's been extremely popular. It's been shared wide and far. And I have no doubt that today's guest, Assistant Professor of Montana University, Rich Willy, his episode will be as equally popular. Rich and I talk about running mechanics, running injuries, and running research. And Rich has spent the better part of his professional career predominantly researching, but also the earlier part of his career as a clinician. So it's that, like Dr. Peter Malliaris, it's that rich blend of practical but also evidence-based medicine that Rich brings to the table. At the time of recording, Rich was finishing up at East Carolina University. Rich is now based out of Montana University, and he spends his time there focusing on running research. You're going to really get a lot out of this episode if you're a runner who's looking to perform at your best. We talk about knee pain, a lot of talk about how to best navigate patellofemoral or anterior knee pain. It's such a pesky injury that affects so many runners. We talk about the role of strength training for runners and why it's so important as we mature through our lifespan. We talk about running shoes. We talk about emergent trends and technology. Pretty much, we talk about everything running research related. However, we're going to get Rich back at some point in the future because there's so much more that we want to explore. So let's jump straight in for Rich Willy. Listeners, this is a real treat. As per the bio, we have Rich Willy joining us today, and Rich is in the US, hails from East Carolina University. And as a physiotherapist, a clinician, I spend 100% of my time working with patients. Rich is one of the engine rooms, I like to say, that drives the research through, which helps practitioners like myself hopefully do the best job we can around giving our patients the best information as it relates to the research. Rich's research accolades are extensive as per the bio, and joining us today is Rich Willy. So Rich, welcome to the Physical Performance Show.
Thanks a lot for having me. It's a real pleasure.
Rich, just to take listeners into your world a little bit, can you give us a little bit of what your week looks like over there at East Carolina Uni as an assistant professor?
Right. So I teach in our physical therapy program, and so we have about 30 PT students per class, and just your standard introductory PT program. I also do a lot of biomechanical research. So we have a fully instrumented motion capture lab. We have an instrumented treadmill and 3D motion analysis system. And so, I look at runners who have injuries. I also do some work with the military and try to figure out why they get some of the overuse injuries that they tend to be prone to. So I spend a lot of time doing research. I still do treat some. I do mostly that on a consultant basis. So I tend to, get like your runners who come in who have seen a couple other different therapists or other healthcare practitioners and are kind of at their wits' end with their running and whatever running injury that they're dealing with at the time. So that's pretty much what I do. I would say probably the vast majority of my time is spent doing clinical research or biomechanical type research on runners.
And Rich, you mentioned there, equipment, state-of-the-art equipment. I mean, the instrumented treadmills, these really are state-of-the-art, devices. Can you give listeners a little bit of perspective around some of this technology?
Yeah, absolutely. So we use the same sort of motion capture technology that you would see in movies or video games or what have you. So we have this multi-camera system, and we put little reflective markers on runners or other types of athletes and have them move and do their normal sporting activities, and we collect data on them. So we analyze their joint angles. We also have them on force plates or an instrumented treadmill, which is basically a treadmill that has force plates built into it. And what that allows us to do is calculate things like joint loads and bone loads and tendon loads and so forth, so we can kind of get a better idea what kind of forces these runners are experiencing and how those things might lead to certain injuries. So our treadmill is definitely a very specialized treadmill. It's a $100,000 treadmill, so it's not something that you're going to see in any sort of typical clinic by any stretch of the imagination. But even so, even though we use very high-tech technology, we tend to try to always bring it back to the clinic. So, we use this 3D motion capture system as our gold standard. And we're always trying to come up with projects or questions that can allow us to take some of our techniques and measures and come up with more clinical or field-based measures so that clinicians and runners can use them in their everyday practice.
And Rich, I mean, that really is I believe, the art of the science, being able to distill
the complex to the take-home pearls of wisdom. Rich, your career, you were a clinician for 8 years, I believe, solid. What got you into the world of physical therapy, into physical performance, if you like, in the first place? Did you grow up as an active kid?
Yeah, I mean, I've been a runner for, I guess 30 years now. So I'm 43 now. So I've been running, organized in an organized manner for a long time. I did triathlons for a long time as well. And so I've always been really curious about it, and I got injured a lot too. So physical therapy was a very natural fit. Once I graduated from PT school in 1999, I started working in orthopedics and sports medicine. I started treating a lot of runners, and I got really interested in working with them, and I wanted to learn more. I kind of felt like the level of evidence that was out there for treating running injuries and runners wasn't very good. So I went back for a PhD, and I went to the University of Delaware and studied under Irene Davis, who's a very well-known and very well-respected running PhD researcher. And, she just opened up a whole new world to me from a biomechanical standpoint, and her approach was something that I really learned a lot from. So I got done with that in 2011 and kind of went back and started doing more research, and I still try to work with runners as much as possible just so I can keep my hands in the clinic. And this is something I really love to do. Every day I come into work, I get excited. I come running up the stairs and thinking about what I'm going to be working on for the day, and really I have a dream job. I mean, if you're a PT and you like treating runners, like me, I mean, you couldn't ask for anything better. So this is a really good gig I got.
That's brilliant. And Rich, as a runner yourself, I mean, your injuries, just for listeners' interest, what injuries have you had that have been your major ones, and how have they delivered or given you an insight into something that I've picked up from listening to you speak and some of your works, is that you have a real keen insight into the psychology of runners, the things to say to runners, the things to not say, the things to be aware of. So obviously your injuries, what have they been, Rich, and how much have they helped you in your role?
Yeah, I mean, I've had just about everything. I feel like I've had patellofemoral pain, so I had that for a couple of years, and that was, as anybody who's had patellofemoral pain knows, it can be a very persistent injury. Stuck around for a long time. I thought that there was something wrong with my alignment and so forth. This is back when I was back in PT school and so forth. And so I think now we know quite a bit better about what causes, patellofemoral pain and how we can treat it. I've also had plantar fasciopathy. I had a tibial stress fracture once. I've had femoral acetabular impingement, and I actually had hip surgery for a torn labrum. And and that's been, I would say that's probably been the most challenging surgery to recover from. And, again, it's funny, I look at some of the treatments that I've had, and in hindsight, I think I would do things a lot differently. And I think that hip surgery was certainly one of those. I probably got a little romanticized into this, hip arthroscopy surgery to get that fixed. And, but you live and learn. So we all make mistakes. And for me, I think one of the things that's really helpful to me when I work with runners is the ability to make peace with your past. And we make mistakes, we all do. And, and also part of that too is understanding that like the past you may not be the present you. And so I think that's an important thing for runners to keep in mind when they're trying to come back from an injury, that they shouldn't hold themselves up necessarily to that standard that they were, 6 months ago or 2 years ago when they're at their peak. And maybe they can get back there eventually, but it's important to compare yourself with who you are today and not necessarily, beat yourself up about maybe some mistakes that you had made. Maybe you feel like you wasted time seeing certain clinicians, or you bought the wrong shoes or something like that. I just think those things are really important for runners so that they can learn to kind of live in the moment and accept some responsibility for where they are and move forward.
Rich, there's such keen insights. I mean, wow, make peace with your past. And I think the perspective is so often skewed, as you say, from people going through an injury that's not necessarily a an injury that's, rehabilitated quickly, that the perspective can be lost. And Rich, you mentioned patellofemoral pain there. I'm on the eve of actually heading up to your former supervisor there. I hear Irene Davis speak in Brisbane at a one-day clinical symposium, which I know you normally attend. But Rich, patellofemoral pain, if I read your bio for East Carolina University there, correct me if I'm wrong, but knees tend to be your keen research focus, at least at the moment. I mean, your professional interest reads as pathomechanics and treatment of patellofemoral pain syndrome and the prevention of knee osteoarthritis in young, high-risk individuals. Am I reading up-to-date information there, Rich?
Yeah, it's pretty accurate, definitely. So, I also studied Achilles tendon injuries quite a bit. So, work with Karin Silbernagel, who's up at the University of Delaware, and Peter Maliaris, and those guys are some real tendon experts. So, I do a lot of stuff with tendon ruptures and Achilles tendinopathy. So, that would be the other area that I spend a lot of time studying. But yeah, definitely patellofemoral pain is my bread and butter. That's what I did all my PhD studies on, and it's something I come back to quite a bit. Even though I might kind of move to like tibial stress fractures for a while, I always kind of tend to drift back to patellofemoral pain just because it's something that just really interests me. And when you look at runners, it's the number one running injury from a popularity standpoint, if you will. So about a third of all running injuries are patellofemoral pain related. And so if you're going to treat runners, you better be pretty good at treating patellofemoral pain.
Yeah, here. And you are speaking to someone, Rich, that, like yourself, grew up with physical activity, triathlon and running, and patellofemoral pain to date has been my number one bugbear that I've had to work through. In fact, I'm working through it. It's been there since a half marathon PB 18 months ago. So I'm going to get a bit selfish on this podcast and ask you a few things. But Rich, let's go there on patellofemoral pain. For the uninitiated, the listeners, can you give us a little bit of definition into what that actually means and what some of the structures that can get irritated may be?
Yeah, patellofemoral pain is a fascinating injury, and it's similar to a lot of other running-related injuries in that we don't really understand where the pain source is. So it used to be thought that it had to do with degradation of articular cartilage and patellofemoral joint malalignment. And, of course, those when you think about those kinds of things, that makes you think about imaging, whether it be MRI or X-rays or what have you. But, recently, most of the work has shown that really imaging doesn't predict who has patellofemoral pain. And if you have patellofemoral pain, you might go in and you might have a perfectly clean image. And so it's a very kind of confusing injury for runners. It can be very frustrating. I think that it's not something that is treated with surgery very well, and I think most of the time surgery is best to be avoided with patellofemoral pain. And but from a PT standpoint, it's kind of a great injury for us to learn how to specialize and from a very high degree, because we can treat this and it responds well to exercise therapy. And as far as our pain sources go, there is some thought that there are a couple different contributors, like the synovium or your joint lining might be part of your pain source. We all have a fat pad just below our kneecap, and that's a very sensitive tissue, and so sometimes that can get irritated. There's also some thought that the bone that lies underneath our articular cartilage can be a pain source. But the really interesting thing about the patellofemoral joint is that your cartilage is not innervated, so that is not your pain source. It's all those structures around your articular cartilage. And so I think that's a really nice kind of thing for runners to keep in mind when they do have patellofemoral pain, that when they think that their knees are falling apart or they've got bad knees or that they're going to get osteoarthritis or something like that, whereas in reality their pain is really probably not coming from their articular cartilage at all. Actually, it most certainly is not. It's probably coming from some other structures. And so much so that there is a school of thought out there that actually thinks we should probably move away from the term patellofemoral pain and instead focus on the term anterior knee pain. whereas it's just kind of like more of a, it's just kind of this global anatomical region where it tends to get, very painful in certain people. It certainly affects women far more so than males, and almost, I think, 2 to 3 times the rate. And so I think a lot of times if we kind of like move away from this kind of this anatomical definition of injuries, I think sometimes it can be an easier injury to treat.
Yeah, so Rich, so much there. I mean, myself, as a 19-year-old, I came off a bike in a triathlon, Rich, and my patella, landed forcefully quite, heavily into the trochlear groove behind it. And a few years later, Rich, while at Physio school here on the Gold Coast, Australia, I couldn't go down beyond like a 20-degree squat without feeling like my knee was just, going to explode. And eventually, tried all the conservative measures, Rich, and I share this because I think it might encourage some listeners. Went off to the orthopedic surgeon. We did an arthroscope, and he found the MRI showed some bone marrow edema. But when he went in, he found a 2.5 centimeter vertical split in the trochlear groove with fluid under there and flaps lifting up. So the best they could do was a microfracture technique, and years later, I was back running marathons and things. But I look back and I wonder, could it have happened that way with the passage of time and not the surgery? Maybe like you wonder with your hip. Is there a relationship, Rich, between the length of people's symptoms with anterior knee pain and their prognosis and the time course for that?
Yeah, definitely. I think the more persistent that someone's patellofemoral pain is, the longer it's going to take them to recover. And I think that's probably going to be the case for most injuries. Achilles tendinopathy certainly is one that comes to mind. But that doesn't necessarily mean that there's articular cartilage damage. And it sounds like maybe in your case, maybe there was some trauma that was involved. And, for most people, it's not in running, and a lot of times it ends up being more of kind of what a lot of people call like an overuse injury. And so I don't know, like there's a lot of psychology in why some running injuries or some runners tend to have more persistent pain than others. And, it may be that those runners maybe tend to make the same sort of training mistakes over and over and over again, and so there may be that aspect to it too. There certainly seems to be some like a genetic component to injuries. Certainly if you've had a family member who's had patellofemoral pain, the likelihood that you may have patellofemoral pain also is relatively high. But certainly time is a really big predictor. In fact, the number one predictor on whether or not you're going to get patellofemoral pain or tibial stress fracture or Achilles tendinopathy is if you've had that injury in the past.
And that's the same side, Rich, the ipsilateral side, or are we talking either side?
That is a great question, and I don't know the answer to that. That's a fascinating question.
That's your next study, Rich.
That is. I don't know the answer to that at all. So,
well, I only asked, Rich, because I referenced my left knee, and here I am, 36, and off the back of a half marathon PB last year, I'm nursing a persistent anterior right-sided knee pain. So, I've had this informal clinical, hypothesis that potentially maybe it's the quality of the cartilage. I seem to see runners and triathletes that have this anterior knee pain on both sides, and I wonder if there's obviously a genetic, as you mentioned, predisposition there due to some of that quality of the cartilage, around the back of the patella, the trochlear groove. I'm not sure. Yeah, well,
the other thing too is that other limb is always along for the ride too. So whatever your right leg is experiencing, your left leg is also experiencing, and that may have something to do too with So there's this. Whenever I work with runners, I try to always talk about this concept of the envelope of function, which is a really great way to explain running injuries to runners, and I think it really works well for clinicians too. And the envelope of function basically is your ability to kind of tolerate load very, very consistently and without injury. And in order to have a high level of function, you have to have taken your time with your training and been very consistent and kind of slowly built up your intensity and your running volume and so forth and gotten it to a certain degree. And so it may be that the reason why the other knee continues to get injured also is that you're rushing your training, or you're making the same training errors with both legs, obviously. And so that might be one of the reasons why we get injuries bilaterally. There are also maybe some biomechanical reasons too. So if you have patellofemoral pain, you may kind of subconsciously shift your load to the other limb, and you end up getting patellofemoral pain on that side because you're loading that limb a little bit more. So there are a lot of different maybe potential reasons, for that. But, there are some things that we do know that a lot of times, conventional wisdom would tell us that someone would get patellofemoral pain. And a lot of the evidence is suggesting that this is not really the case. And those factors would be, we know that height doesn't really have much to do with who gets patellofemoral pain. So I know certainly when I was younger, it used to be thought that people who were taller tended to be a little bit more prone to patellofemoral pain. We know body mass index doesn't seem to predict who's going to get patellofemoral pain. And for me, I think that's a great message for runners who are new to running, who maybe are looking to lose a little bit of weight. They shouldn't really worry about getting or developing patellofemoral pain. Maybe they need to go into their running program a little bit slower, just because they're overall deconditioned. What are some other things? Like overall, like lower extremity alignment. Even though it used to be thought that had a big role in who developed patellofemoral pain, the evidence doesn't support that at all. And part of that is what we call the quadricep angle, or Q angle, as it's commonly known. That also doesn't seem to predict who develops patellofemoral pain.
Yeah, it's. I remember reading a little book called Triathlon into the 90s, published here in Australia as a high school student, and seeing the Q angle referenced and looking at my own legs, Rich, and I've got a bit of tibial torsion, genu varum, and thinking, well, I'm doomed. I have had some patellofemoral pain over the 20 years of running, as I've referenced, but it's interesting that now the research comes through and it validates that biomechanics aren't necessarily, it's not so cut and dry. Rich, that BMI that you referenced, that's fascinating. Clinically, I tend to look at things, and if someone's carrying excess frame weight, then I would normally liken it to be a potential contributing factor for any lower limb injury, but you're saying the research doesn't necessarily validate that specifically for knee pain, anterior knee pain.
Yeah, to me that was a real surprise as well. But yeah, when you look at these like meta-analyses type studies where they combine the data from several different prospective studies, and they look to see, they basically can have a massive sample size with that. What that does is it kind of reduces some of the bias or the influence that certain biases might have with the way the data were collected and analyzed and so forth. And what it turns out is that, the BMI doesn't really seem to play much of a role in patellofemoral pain. Now, it may lead to some other aches and pains for sure, and we know that higher body mass increases one's risk of developing tibial femoral joint osteoarthritis. So that's not your patellofemoral joint, but also your knee, but and it may increase your risk of developing some other injuries. We know that as your adiposity goes up, that it may increase your risk of certain tendinopathies and so forth. But when it comes to patellofemoral pain, BMI doesn't. I think people should spend their time focusing on other things that they can really do something about, which would be like strength training and slowly building up their running volume and intensity and going from there.
And we want to definitely touch on strength training. Just before we move over to strength training, Rich, just still on this knee pain, anterior knee pain, patellofemoral joint pain, Rich, just to get real practical for listeners so they can listen to this and walk away with some clarity. Rich, what would be the three, I know there's more, I know I'm pushing you here, but if you had to sort of give three key takeaways for people managing anterior knee pain from your body of work and your clinical experience, what would they be?
There's no magic pill, so there's no magic bullet when it comes to patellofemoral pain. But so that's one thing people should understand, and people should also understand too that patellofemoral pain it gets better with exercise therapy. So people, if you have patellofemoral pain, seek a practitioner out who is going to put you into an active program, one that really emphasizes strength training, particularly quadricep strength training, perhaps hip strength training. I think the other aspect of that too is when it comes to run training, it's okay to have a little bit of pain when you're strength training and also when you're running. And if you have patellofemoral pain, I would caution you not to avoid having like a no pain kind of limit, like where you're saying, okay, if you have any pain, running's bad. And I don't think that's the case. I think that we need to keep moving, and whether that be with running or cross training or what have you, and also strength training, those are things you should be doing too. But if you are having patellofemoral pain, there are lots of different ways while you're increasing your tissue tolerance through strength training to offload your patellofemoral joint. And that's when like a gait evaluation can be very, very helpful, when you can see someone who really understands running gait and understand what maybe contributing to greater patellofemoral joint loads, how you can alleviate that. And that might be just doing some real simple things with changing your running cadence or working on your alignment when you're running or something along those lines. So I think those would be the things that I would really focus on. Would be active therapy, keep moving, keep running, doing strength training, and if need be, look at changing your running mechanics, and if so, just change your running mechanics for the short term.
Brilliant, Rich. Thanks for obviously distilling so much into 3 practical points. Rich, you mentioned there running training, gait retraining, and also strength training. Can we shift gears over to speak about, you've done a lot of work on both of these areas, particularly the running mechanics. Can we go there maybe first? And Rich, we've just sort of spoken about the importance of looking at running mechanics potentially for knee pain. Specifically on that, what things might a runner be looking for that they could potentially modify to help with their knee pain symptoms, Rich? Yeah,
so when we look at running retraining, it used to be that I used to think that we had to fix a runner's running mechanics. We, quote unquote, had to fix it. But now I've kind of come around to the idea that I think we really just need to probably alter the way a runner moves, just for a period of time, until they can kind of build up their overall tissue tolerance. So I think that before anyone embarks on any sort of gait modification program, I think it really should be guided and should be very prescriptive, meaning that they're seeing someone who understands gait analysis and can make an informed decision on what type of running gait modification someone should do. So with that said, let's say you go see someone, you get a gait analysis and so forth. One of the easiest ways that a runner can reduce patellofemoral joint loads is by increasing their running cadence. And by increasing your running cadence, which is just the number of steps per minute when you're running, by about 5 to 7.5%, you can reduce patellofemoral joint loads by up to 20%. So that's a pretty big reduction, and it's huge. Yeah, it's huge.
It's huge, and so if we increase it, if they need to increase their cadence and they do that 5 to 7.5%. What are the practical tips a clinician or someone running can think about to increase that? There's obviously the literature supports own strategies, people just figuring it out themselves. But have you got any real practical tips that you found that help runners be able to do that, Rich, to increase their cadence, their turnover rate?
Yeah, so I think anytime we're looking to change a movement pattern, you have to have some form of biofeedback. And a biofeedback is, just like it sounds, you're getting feedback on how you're moving. And so a running cue, where someone's giving you instructions on how to move, typically isn't going to be enough. And so you need to receive some sort of feedback. And whether that feedback is visual through video or from a mirror, or internal, you're really kind of sensing the way that you move, or you're getting feedback in a very objective manner. And so that's what we've tried to do. We've moved towards using wearable devices to give feedback on step rate, and we don't use anything fancy. We use just a standard running computer like a Garmin. Or like a Sunto running watch. If you have one of those, if you have a GPS unit, chances are if you dig around through your instruction manual, you can figure out a way that device will be able to give you running cadence in real time. And so we give people a targeted range in that 5 to 7.5, maybe up to 5 to 10% over their preferred step rate. And these running computers, they're very precise for step rate. They're very accurate. We've validated several of them in our lab for the studies that we do. And I feel really confident that they're a really nice piece of equipment for runners to have. And, if I can convince people, anymore, if you have patellofemoral pain, and running Cadence is something that seems to improve your symptoms. These running computers have really come down a lot in price. In the U.S., you can get a very nice running computer for maybe $125, and that's pretty inexpensive when you're looking at the grand scheme of repeat physical therapy treatments and so forth. And this is a device that can continue to give you feedback on how many steps per minute you're taking and so forth.
Yeah, and Rich, for people that aren't accessing a physical therapist or a physiotherapist or a health professional to help them with their running gait reach running, they're hearing this and maybe they're, okay, I'm going to think about my cadence, my turnover rate. You mentioned the term preferred step rate. How can people figure out their preferred step rate, Rich? I mean, I typically would get people to do a manual count initially as opposed to looking at technology, but what are your preferred methods for that?
Yeah, the manual count works fine. I mean, all you got to do is count your foot strikes for 20 seconds and multiply that by 3, and that's going to give you your steps per minute. The running computers are really nice too, because you could just go for a run, and when you get back from the run, you can look at your average cadence for the entire run, and then you can base your prescription of your new running pattern based off that. There are a couple other devices. There's an app out that's called Run Cadence, and that's certainly worth taking a look at. It's very inexpensive. I think it's about $9 or $10, and it's you just wear your phone on your arm, like your standard, I guess armband that if you're really into running with your phone, and it uses the sensors to give you feedback on running cadence there too. So you don't necessarily have to spend a lot of money to be able to get feedback on your running cadence, or even to figure out what your baseline running cadence might be.
Yeah, great. And Rich, running technique, from a research point of view, from a clinical point of view, the two worlds that you straddle, what would you say for listeners are the key attributes or characteristics of, it's an open question here, Rich, but of good technique? What are the hallmarks that would give you some comfort looking at a runner? So I guess my opinion about running gait is that if you're running and you don't have an injury and you don't have pain, I don't mess with it. I don't tend to change anything about the way someone's moving unless I feel like it can alleviate or reduce some of the load on a certain anatomical structure. So if someone has had a recent tibial stress fracture, and we know that if they have high impact forces, that we know that there are certain things that we can do. Increasing your running cadence is the easy one. It's going to reduce your impact forces. But otherwise, I don't get too worried about like an ideal running technique. I feel like if someone's running and it's working for them, that's the ideal running technique for them. Yeah, brilliant. Well said. Rich, let's talk strength training, the role of strength training in running. I mean, we've touched on it specifically, the importance of strength for patellofemoral pain, knee pain, but what are the key messages listeners need to be aware of for their own either injury proofing, if you like, or certainly rehabilitation when it comes to strength, Rich? Yeah, so most runners do not strength train, and at least the ones that I end up working with, and the ones that do tend to, they tend to do a lot of body weight exercises, so a lot of maybe like single leg squats or something like that with either no weight or very, very light dumbbells, and they tend to do higher repetitions. And one of the things that I tend to encourage runners to do is when you're strength training, you're strength training. When you're running, and don't mix the two up. So if you're strength training, don't be messing around with high repetitions. And I think that comes back to understanding the levels of these loads that we experience internally. So Achilles tendon forces when we run tend to be very high, 6 to 7 to maybe even 9 body weights of Achilles tendon force when we're going out for an endurance pace run. Patellofemoral joint loads also end up being about 5 to 6 body weights of load. Now, that doesn't mean you have to load up
500% of your body weight on the knee extension machine to accomplish these types of loads. All you have to do is work on doing isolation type exercises. So I think that's the other thing too, is that I tend to encourage runners to, look, single leg squats are great, and I certainly prescribe them. But for me, if I'm faced with a runner who has a very limited amount of time, they can get into the gym and they can maybe do a couple exercises before they go for a run. I put them on a knee extension machine or a calf raise machine and do some isolation type exercises, because otherwise it's going to be very, very hard for that runner to accomplish muscle or tissue loads that are somewhat equivalent to what they might experience during a normal run. And so that also means lower repetitions. So the repetitions should be, somewhere in the 6 to 8 repetition range, and they should be exhaustive. So by the end of that 7th or 8th repetition on your third set, you should be pretty worn out. And I think those things are really important. You shouldn't, when you're working out, you should be, if you're listening to music, that's great, but make sure you're strength training with a high enough intensity. And there's some really good science supporting that too. When we look at strength training, and the group out of Denmark who does a lot of really cool stuff with tendon and so forth, they've found that if you go into the gym and you do knee extension exercises, and I think they just kind of arbitrarily chose 10 sets of 10 repetitions, and it was, I think they were looking at 65% of what you can do for one repetition. And they did that, and what they found that the amount of collagen or new connective tissue that you lay down in your patellar tendon ends up being equivalent to what you would experience if you go out and run about 40 kilometers of running. And to me, that's absolutely fascinating. That's amazing. Wow. That means that you can go into the gym and you can prepare your tendons for high training volume without even leaving the gym, and you can get your tendons in shape in the preseason to prepare yourself for the loads that you're going to be experiencing 2-3 months from now when you're in the middle of your marathon training.
That's a phenomenal finding, isn't it? It really speaks to something that, I think a lot of runners these days, Rich, are aware of recreationally, certainly at elite levels. But as you mentioned, people are time poor, and sometimes that thought of having to do something else when they just want to go and run is a bit overwhelming, so it gets pushed to the side as not urgent but important, and it doesn't happen yet. It seems to be that's just such a mistake to make if we want to have the resiliency, the capacity in our tissues to absorb the loads that we want to put our body through for getting our best performance as runners, right?
Yeah, absolutely.
And so, Rich, just to give us perspective, I mean, isolated work, it doesn't need to take long. What we're talking about, maybe a half an hour block twice a week.
Yeah, that's it. That's it. And if you can kind of think about that as that 1 hour investment is inoculating yourself again. And I can't sit here and say you're going to injury-proof yourself altogether, but you're increasing your entire body's your tolerance to the types of loads that you're going to be experiencing during running. And for me, that's money and time well spent.
And it's interesting, Rich, one of your colleagues, your professional colleagues and former expert guest of the podcast, Peter Maliaris, tendon specialist, Peter talks about, and I love this, I've adopted this clinically, the need to isolate things, to obviously develop that capacity. Yet the move in fitness, certainly here in Australia, I believe so in the US, is, just generally has been, to the functional stuff, the CrossFit type movements. And so it's quite uncommon to see people doing those isolated things these days. Would you agree? There's been a real shift away from that, just at a trend level?
Oh, yeah. Oh, totally. And I was part of it too. I mean, 10 years ago, I was coming up with all sorts of functional exercises, people balancing, doing squats on balance boards and coming up with all different configurations for single leg squats or what have you. But the problem when you're doing that is that let's take that balance board exercise. You're working on your balance, and that's great, but the strength loads are just sub physiological for what we would experience during running. And then let's maybe reduce it a little bit more and just go back to a single leg squat. So when you're doing a single leg squat, the load is being absorbed by your plantar flexors as you're dorsiflexing, your quadriceps, your hamstrings, and your glutes. And so you've got the load from your body, and maybe you've got, I don't know, 25-pound dumbbells in your hands or something like that. But that load's being absorbed by all those different joints and all the muscles attached to them or that are crossing those joints. But if you do an isolation type exercise, you're going to, let's say you just stand up straight and you do some single leg calf raises. Now you're isolating all of that load through your plantar flexors. And that's how you get to those loads that are equivalent to what you would see during running without having to run.
Yeah, those super maximal, loads. In terms of other things in that gym session, I mean, practically we could be doing some calf raising loaded. We could be doing some leg extensions, prone hamstring curls. What would be a couple of other key exercises, Rich, that listeners could get done?
Yeah, I mean, I think that a Bulgarian split squat is a great exercise. And I know just kind of sat there kind of beating up on squats a little bit, but that's a really nice exercise because you can adjust your trunk position really quite well. And then you can, if you lean forward a little bit more, you're going to really increase the load on your hip extensors. If you stand up very straight, you're going to load your quadriceps quite a bit more. And so that's a great exercise to kind of add in addition to kind of your isolation type exercises of doing your calf raises and your knee extension machine. I also really like single leg Romanian deadlift. I think that's a wonderful exercise for runners. And while you're standing but you're doing that exercise with a single leg and you're flexing forward at the waist. That is a great exercise to really load your hip extensors and so your gluteus maximus and your hamstrings and so forth. But when we look at the muscle loads when we're running, and I think one of the things I think can be very helpful with, for a runner when they're looking to prioritize where they should be strength training is look at where, how much contribution is coming from each joint when we run. And about 50 to 55% of our contribution to running is coming from our ankle plantar flexors. So that would be like our gastrocnemius and our soleus musculature. And to me, that still totally blows me away. And all you got to do is look at the size of your Achilles tendon. That Achilles tendon is massive, and that's because the loads that go through there are so high. And then next we go up to your quadriceps, and your quadricep force, contributes about a third. And then up at your hip extensors, this is just for endurance-based running, is really quite low. Your hip extensors, they tend to only contribute about 15% of the load to our running. Now, again, that's with endurance-based running. When you start running very fast, sprinting, for instance, now that's when you're talking about your hip extensors become extremely important. But regular endurance-based running, it's primarily a plantar flexor and quadricep activity, and lo and behold, that's where we get most of our running injuries.
Gosh, that's absolutely fascinating. I mean, it's hard to, even as a clinician, Rich, spending years around this, it's hard to truly absorb that half the work comes from the calf complex. It's if you look at it size wise, even though the Achilles tendon, as you say, is a big tendon, the muscle itself's not a big muscle mass compared to something like the quads or the glutes. It's quite outstanding, that finding, isn't it?
Yeah, it is amazing. But when you look at the muscle architecture, the pennation angle, or the angle that these muscle fibers are coming into that central tendon, is very high. And so the amount of muscle fibers that are packed into your soleus is absolutely massive. And I think the pennation angle in the soleus is one of the highest in the entire body. I mean, it's this monster in our lower leg, and we often ignore that when it comes to our strength training. And I really think that's when we look at runners, particularly older runners, because that's where they tend to get a lot of atrophy. That's where they should really be, spending a lot of time working on doing some single leg calf raises, both with a straight knee and also with a bent knee.
Hitting the soleus, and it's been certainly, from a clinical perspective, I've seen it really emerge more strongly recently, I think, with some of the work that's been coming out, just the importance of the soleus in things like Achilles tendon rehabilitation and obviously other lower limb injuries. So the best way to target that, Rich, is just to simply get up to a wall and bend the knee and start raising up and down, right, for listeners. But you can add weight as we go.
Absolutely. Yeah, if you want to do it, if you're strapped for equipment, just put on a backpack and load it up. you can do that. You don't have to get high tech with the way we're doing these exercises by any stretch of the imagination. And the other thing too is your increased strength can really have a big load on your bone loads also. And so for runners who have medial tibial stress syndrome or a lot of people call it shin splints or tibial stress fractures, those type of injuries are also associated with a calf musculature that shows it tends to be low atrophied. And so a strong calf muscle will offload the bone by absorbing some of the load, definitely.
Yeah, and I mean, that just commonsensically, fits, right? But once again, I find it so often overlooked clinically and just recreationally outside of a therapy environment for runners. So thanks for sharing some insights there, Rich, around the importance of strength training. Just want to touch on, Rich, there's so many places we could go with this. There's so much you've got to share and offer listeners. So I just want to just touch on two things. One would be the changes in running mechanics with aging and how that relates to different injuries as we run throughout our lifespan. What are the key messages you've picked up through your work to date around that, Rich?
Yeah, so this is something that, and maybe this kind of mirrors where I am in life. I'm 43 and so I don't have patellofemoral pain anymore, but I look at the runners that come to see me a lot, and they tend to be more middle-aged runners. And those runners tend to have more issues with plantar fasciopathy, Achilles tendinopathy, and so forth. And so and it's really interesting when you look at the running biomechanics as we age. One of the things that happens is that we tend to offload our calf musculature a little bit. So we don't push off quite as much. We tend to where we're getting our muscle forces when we run tends to move a little more proximal. So it moves up towards our knee and up towards our hip extensors. So, and it's really interesting because when you look at the calf musculature, our Achilles tendon actually loses some stiffness, and that might be a little bit counterintuitive because I think a lot of times when people think about someone who's getting older, they think that they're getting stiff, and so forth, and they may feel stiff, but their tendons are actually becoming less stiff, and that's because you're starting to lose some collagen in those tendons, and as a result, our tendons don't store and release energy quite as efficiently. And that Achilles tendon, then when we run, it tends to get overloaded a little bit more easily in the older runner. And the runner that I'm specifically thinking of tends to be your male masters runner. So in fact, that's the number one injury that male masters runners tend to get is Achilles tendinopathy. So there are a lot of different things for a runner who maybe is an older runner who is dealing with some chronic plantar fasciopathy or Achilles tendinopathy. And I'm sure Peter Maliaris in your previous podcast hit on a lot of those things, but I can speak to some of the things from a running standpoint. Of course, the strength training, that would be, we would definitely get after that. And if you can kind of think about most running injuries from the idea that, you want to do something to kind of offload the tissue at the same time you're working on it, increasing the tissue tolerance. So we can increase our tissue tolerance down there by doing the strength training, of course. But to offload the tissue, you can do a couple different things. You could try out some different shoe designs. So we know that a really mild rocker bottom soled shoe reduces the load on your Achilles tendon. And I don't know if you can get these shoes in Australia, but Pearl Zumi has a shoe that has a little bit of a rocker bottom to them, and that's a really nice shoe design that can, a lot of the older runners I work with tend to really like quite a bit because it reduces some of their Achilles tendon loads. You can do some other things like just like a heel raise, like a little heel wedge, to put you in a little bit more plantar flexion, which will also offload your Achilles tendon and so forth. But yeah, so that's the kind of the main pattern that we see when a runner is getting older is that our contribution to our locomotion starts to move up towards our trunk. So we tend to get more loads from our knee and our hip, but our injuries tend to focus much more so distally. We tend to get many more injuries on our lower leg and our foot and ankle.
And so if you are one of the masters runners that you referenced, Rich, frustrated by tendon problems, certainly jump back, listen to Peter Maliaris share around tendons, but also take what Rich has shared on board and Rich, that'll be strength training to help the tendon stay stiff and absorb the loads, and also deloading strategies, right, Rich, like rocker bottom shoes or potentially heel raises, wedges, those sorts of things.
Right. And we're just talking like a mild rocker bottom. We're not talking about the the butt toning rockers that were out a while ago. No, these are real mild rocker bottoms.
Yeah.
I think Scott makes some shoes that has a little bit of rocker bottom to them as well.
Yeah, I think in some of the Hoka range have a slight rocker bottom, right?
That's correct. Yeah, absolutely.
Yeah. So Rich, so great, thank you. And the role of shoes, we've just touched on, extreme rocker bottoms and mild rocker bottoms, but what are the role of shoes when it comes to running injuries, Rich? I certainly see an attribution bias around footwear, where we all want our injuries to be due to the fact that we're running in the wrong shoes. It would be so simple, wouldn't it, Rich? But what have you learnt so far or recently around the role of shoes when it comes to running injuries and our running mechanics?
Yeah, I mean, I think you kind of hit on it, that I think running shoes are kind of a easily targeted kind of culprit for running injuries, and in reality it doesn't really tend to contribute very much to why people get running injuries. And I think too, when a runner has an injury, I think that a lot of times they start spending some time looking for new running shoes, and I think that they might be doing that because it's potentially a very quick fix. It's also actually relatively inexpensive to buy a new pair of running shoes versus maybe going and seeing a highly skilled PT. So, I think when I look at running injuries, I don't typically get very excited about running shoes. I used to. I definitely kind of, I did some work looking at minimalist type running shoes, and for a while there, I was like, oh, this seems kind of really interesting. And I ran a marathon in a pair of minimalist running shoes, and I did just fine in those and everything. But now I run in kind of your standard cushion shoe. It's nothing special by any means. But for me, typically, the only time I get really excited about running shoes when it comes to certain running injuries would be foot and ankle injuries. So if I have a runner who's coming in who has who's had some fourth and fifth metatarsal stress fractures, I'm going to pay very close attention to that runner's foot and ankle mechanics, and particularly how they're interacting with that shoe when they're running. Is this a shoe that is shifting their center of pressure or where they're loading to the outside part of their shoe? That's something I'm really, might be really concerned about. And then, the opposite of that would be true for like someone who maybe has like sesamoiditis, those little bones right behind our big toe. If those get a little bit irritated, is this person running in a shoe that's putting a lot of pressure right underneath that area? Other injuries that I might care about would be like Hallux Valgus or Hallux rigidus or something like that, where your big toe gets very stiff and maybe a little arthritic. So generally the overall kind of shoe advice I give runners is I tell them, look, go for a running shoe that you like. Go to a running shoe store, try on several different pairs. Take the advice that the people are giving you there. Listen to them, but at the end of the day, you're the one who has to run in that running shoe. So don't let someone else talk you into a pair of running shoes that don't work for you. Take them out, run in them, make sure that they fit you from a width standpoint and also from a length standpoint. I see a lot of runners that are running in shoes that the toe box is maybe too narrow. And there's this idea that the shoe that feels the most comfortable to you is probably the right running shoe for you. And don't overthink it. Just keep it pretty simple.
Oh, and Rich, I have to laugh when I discovered that through the literature. The comfort tends to be or seems to be one of the most likely predictors of a good shoe fit. Our mums were right, weren't they, Rich? If we rewind the clocks back to our junior years, where they'd cart us off to the shoe shop and they'd say, "Does it feel good? If it feels good, get it." So I have to laugh at the simplicity of that, but the beauty in it as well.
Oh yeah, it's awesome, and I think that it's important for runners and clinicians to keep in mind that running shoe companies are first and foremost, they're fashion companies. They come out with a new shoe model every year, and mostly what's been updated is just how it looks, your overall appearance, and maybe they might make some changes in the fit, which can be really frustrating. But these are fashion companies; they're not injury prevention companies, and they're very careful to make sure that they don't say that, because if you remember Vibram, the 5-finger shoe glove kind of things, they got sued over that because they were promoting this shoe that was going to potentially reduce runners' injury risk, and those are things that they have to be very careful about saying.
Yeah, certainly.
Shoe comfort is important.
Yeah, Rich, what are you most, in bringing our time today towards a close, there's so much we could talk about. Rich, what are you most excited about professionally at the moment in your work?
Oh gosh, I think for me, I think some of these wearable devices I think are so exciting, because for me it allows us to bring our motion analysis lab outdoors. And so we've started doing some stuff where we use these wearable devices to do gait retraining out in the field, so people don't have to come into the clinic to see us. But now we're starting to use them to do some evaluation on runners. And I think when you think about what you can get out of these devices is really, really fascinating. And it allows us also to have the potential to do massive running injury studies. And so in the past, like a large running injury study might have 300 runners in it. And now with some of these wearable devices, you might be able to get a device on 3,000 or 4,000 runners, and then you can really start trying to figure out what causes some of the more obscure types of running injuries, like maybe, like I said, metatarsal stress fractures. What are some running, not just running biomechanics, but these things also have the capability to look at running practices. So how much is this person how much are they increasing their running volume per week? How much speed work are they doing? What kind of surfaces are they running? These are for a sensor that has been validated well. They'll be able to assess all of those things. And I think taking that biomechanical information if you couple that with some psychosocial metrics from runners, I think can be really powerful. So like looking at how stressed a runner might be, how much are they sleeping? Those things that's a whole area that really hasn't been paid much attention in the past, but I think a lot of people are really starting to pay a lot of attention to these kind of the overall psychosocial impact that the running injuries can have, but also how psychosocial influences can really impact whether or not a runner is going to get injured and how quickly they might recover from an injury.
So it sounds like you got another 5 decades of research ahead of you, Rich.
Yeah.
Endless, isn't it? Just amazing. Rich, those wearable technologies, if listeners, are motivated to get some of that information to them, I mean, what can they practically do? Pick up a device, you mentioned, Garmin's, etc. Any other sort of key devices that you think are good at the moment and price-wise as well?
Yeah, I mean, first, I think it's worth saying that I have no financial relationships with any of these wearable companies by any means. It's just something that we use in our lab, and we use it from a clinical practice standpoint. But yeah, I mean, I think that, getting there's a happy medium, and I think that when you look at like a GPS running computer, like a Garmin would be a great device, one that can give you feedback on running cadence, and so you can kind of maybe start taking a look at that. There's some other real inexpensive devices. Milestone FootPod makes one that's only $25. It can store, I think, up to about 24 hours worth of running data, and it's just a little pod it's maybe like the size of 2 or 3 quarters stacked on top of one another that attaches to your shoes. Those are really nice devices. RunScribe is another company that makes a little device that I think is probably more so geared towards clinicians, but that measures your impact acceleration, so it can measure how hard your foot's hitting the ground. So yeah, there's a lot of new devices, but I think the main thing that we should be very careful too, that there's a flip side to this, and that runners tend to be very type A personalities. They can get very analytical and very worried about their data. And I think the connectivity that comes with these devices, I see a lot of runners get Strava injuries, if you will. I don't know if that's Strava.
Yeah, absolutely. Yeah.
Where they're doing a lot of they're in this online community and they're out running. Maybe you're even running by yourself, but you start thinking about, look, when I put this run up online and all my friends who I normally run with see the run I did without them, I want them to see how fast I ran, and I want them to see how far I ran. And I think that can really influence some poor training decisions.
It's a fascinating landscape, isn't it? Something that never existed a decade ago. So, Rich, if you could boil everything you've learnt, this is an almost impossible question. I'm going to test you here, Rich, into one bit of advice for listeners to perform at their best, be it running, be it any physical pursuit. What would your one bit of advice be, Rich?
Oh, I think make the time to strength train. Yeah, absolutely.
Wow.
I think particularly as we get older, make the time to strength train.
And Rich, we like to have every guest of the show issue listeners with a physical challenge for the week. So that can be entry level, that can be moderately hard, or it can be extremely difficult. What's Rich Willy's, and excuse listeners my voice, what's Rich Willy's challenge for the week going to be?
Oh, geez, I think that would be go back to the strength training and just get in there and do some calf raises and start working. Dust off that old knee extension machine in the corner of the gym that doesn't get a lot of attention, and start off with some easy weights for sure. Go strength train, get in there twice a week.
Beautiful. I'm going to personally take that on as a challenge, Rich, and start to prioritise it in my week. So thank you very much. If we're non-clinicians, Rich, obviously the clinical community knows where to find you. You're prolific, Rich. You're such an engine room of research. But if we're a non-clinician, we're just listening in, where can we find out more about the work that you're coming out with? Yeah,
so I'm on Twitter, and that's a good place to find me. I tend to be fairly active on there. I think it's a good community. So my Twitter handle is rwilly2003. And otherwise, folks are more than welcome to email me. My email, the best email to reach me at is rchwilly@gmail.com. And I tend to be pretty good about getting back to folks. And I would say that if more than a couple of days have passed since they send an email, feel free to send a follow-up one and pester me a little bit. I certainly don't mind. So I really enjoy talking with people, particularly after a podcast or a talk or something like that. So I guess don't be shy to reach out.
Rich, that's very generous of you. I know I appreciate that, and so do listeners. So Rich Willy, thanks for sharing just some of the pearls of wisdom that you've got from all your years of learning with us today, and mate, we wish you all the very best. And down the track, I think I'd like to do a part 2 with Rich Willy. There's so much you can offer the community.
Thanks a lot, Brad. It's been a real pleasure. I really enjoyed it.
Listeners, I trust you enjoyed another episode of the Physical Performance Show featuring Rich Willy today. If you did, please let Rich and I know. Hit us up on social media. Let us know what it was that you took away that jumped out. This is a really practical interview today where we focused on an expert. And just as previous experts were featured, if you know someone that this could benefit, please take the time to literally share it from your smartphone wherever you're listening. Click and send it, and let them in on the insights as well. That'd mean a lot to myself and also to Rich. Jump over to pogophysio.com.au and you'll find the show notes there, and also all of Rich's handles and research articles if you want to go deeper into that world. An enormous thank you as always to the good folk who make the Physical Performance Show possible each week. Mr. Daryl Misson, audio engineer extraordinaire. Thank you, Daz. And of course, Susan Wilkins, adminaholics, who is just amazing with all the back-end support. So thank you, Susan and Daz, for making the show possible. Listeners, if you haven't yet subscribed to the show, be sure to do that. You can simply hit subscribe from within your app, and that'll populate the show each and every week into your device. Lastly, if you're into running, and I suspect you may be, then be sure to check out my Amazon running and jogging bestseller, You Can Run Pain-Free, available across all platforms, audiobooks, iBooks, and Audible. Post it in the audio version, also in the good old paperback version via pogophysio.com.au, domestically or in Australia, or Amazon, of course, shipping internationally. Coming up on next week's episode of the Physical Performance Show, we keep the running theme going, and we keep the American theme going. And next week, we catch up with Bob Larson. Bob Larson is a Hall of Fame track and field athletics coach hailing from the Mammoth Lakes Track Club in the US. And I first caught up with Bob at the 2015 New York Marathon, where Bob was there with his longtime athlete, multiple Olympic representative and Olympic medalist in the marathon, Meb Klavetsky. And at the time, a movie about Bob's coaching career had been released called City Slickers Can't Stay With Me. And Bob and I struck up a conversation after a bit of an interview that was being done with Meb and Bob, and we shared some stories, and said we must get you on the podcast, I said to Bob at some point. So a couple of years later, we've made that happen, and listeners, you're in for a real treat. Bob's an incredible coach who has modelled excellence right through his career. He's taken athletes through to Olympic silver, such as Meb Klavetsky in the 2004, those we need to edit that, the 2004 Olympic Games in Athens, breaking the US 20-year drought of a medal in the marathon. So Bob's got so much to share, some real practical stuff that we cover about pacing and training strategies. Be sure to tune in next week to the Physical Performance Show. Until then, keep pursuing your physical best. I'm Brad Beer, and this has been the Physical Performance Show.